today. Thank you for joining us for Medical Grand Rounds. Before we introduce our speaker, just a reminder to please let us know that you were present at today's rounds by answering a brief survey at the end of the presentations, and that please enter your questions in the chat at the end of the presentation. It is a great pleasure to bring in Dr. Rami Saleh today, who will be introduced by the head of the Division of Medical Oncology, Dr. Alcindor. Terry, are you ready to make the introductions?
Thank you, Nadia. Thanks. So it's a great pleasure indeed to present one of our latest recruits in medical oncology, Dr. Rami Saleh. Dr. Saleh got his MD degree at the American University of Beirut in Lebanon. He came to McGill for a residency in internal medicine and a Master's of Science in experimental medicine, followed by fellowship training at the University of Toronto at the Princess Margaret Cancer Center, where he specialized, among other things, in early phase clinical trials. He's here today to talk about a new era in medical oncology. Thanks.
Thank you, Thierry. Hello, everyone. So today we will talk about the new era in medical oncology, basically focusing on immunotherapy as well as upcoming medications and the management of their side effects. Hopefully you can all see my slides. So I have no disclosures to report. The objective is to go quickly and briefly on the history of cancer treatments, how it all evolved, as well as the effects of cancer survival rates. To mention new treatments that we are being exposed to, especially in the last 5 to 6 years, such as immunotherapy, targeted therapy, new medications that we will start seeing soon, or we just started around 2-3 months ago, known as antibody drug conjugates, as well as how to manage their side effects, given that oncology right now and oncological patients necessitate more involvement from other departments. And I will finish with a brief description on what we're doing at the MUHC and leave it for questions and answers at the end. So cancer treatments across the centuries, we're becoming less invasive for sure and more targeted. Just oncology, I would say, was as easy as the metro station of Toronto, I would say in the early 1900s, and now it is as complex as the Tokyo subway station. I always like history going back in time. It was the Egyptians 3000 BC who described the first tumors in civilization. Hippocrates 400 BC also attributed cancer to food, at the time bile. It was only surgery that was done in the early, I would say, AD. In 1800s, Marie Curie discovered radiation, and that exposure to radiation can help fight tumors. Post-World War II, it was noted that nitrogen mustards that were used in warfare can actually be useful as chemotherapeutic agents against cancer. I think that was the only positive in a world war, and that's where chemotherapy came into play. And then in the 70s, this is when we became better radiologically in detecting cancer. And then in the late 1990s, this is where the targeted therapy came, and 2010 immunotherapy. So on an easier slide, I would say the hallmarks are radiotherapy. 3000 BC would be surgery, and then radiotherapy in the early 1900s, chemotherapy in the 1940s, which is slowly being replaced by targeted therapies and lately checkpoint inhibitors. So what are the effects of new treatments on cancer survival rates? We are definitely getting better. It is very well seen that we have this misconception that oncology is always bad, and that is always because of what we see in the emergency room, but we are definitely getting better. I know that right now we use our world in data to check how we're doing with COVID, but our world in data published the 5-year cancer survival rate in the United States, and they compared the 1970s to the early 2000s. Mind you, this was at the beginning of the discovery of immune therapies in the early 2000s. So those numbers are actually underestimated. But in all cancers, we went from 50% at 5-year survival to 67%. Targeted therapy did push a couple of, I would say, oncological subfields, such as prostate, breast, and brain. And immunotherapy did give a big push to a lot of the tumors in order to have a better prognosis. So we are generally doing better. The two that are getting worse, which are the cervix and the uterus, the reason why we're worse is because of lower vaccine rates, mainly in the United States. Okay, so what about new therapies? We are slowly switching from treatments that focus on the cell cycle to targeting something intracellularly. So traditionally, we focus on surgery, radiotherapy, and conventional chemotherapy. The modern era is mostly focused on molecular targeted therapies, immunotherapies, and others. When I was a medical student and as a resident, we always used to remember the cell cycle, and this is where cancer treatments mostly work. But we are slowly shifting away, given that we now understand intracellularly what goes on, what actually activates the cancer, what are the driver genes, and what are the genes that actually inhibit a cell from becoming malignant. In an easier fashion, there are a couple of targets that we are focusing on lately in the last 10 years. If you see my mouse, CTLA4 as well as PD1, this is the immunotherapy area. And lately with phase 1, phase 2 trials, we have anti-LAG3 as well as activating receptors such as CD28, OX40, and jitter that are being focused on right now in medical oncology. So we are becoming better. Targeted therapies have been there since the 1980s, I would say, but more focused. So they could be either extracellular, such as monoclonal antibodies, or intracellular. We call those tyrosine kinase inhibitors. A case that I saw when I started as a research assistant when I came to McGill was the 52-year-old woman with invasive breast cancer that was ERPR negative and HER2 positive. Those are the receptors in breast cancer. She wasn't doing that great because her performance status was ECOG 3, and she was stage 4. When we ask around a lot of the residents, especially in internal medicine, stage 4 cancer, everybody says, oh, bad prognosis, should be less than a year, but this is becoming more false lately. We're having better survival rates and improvement in quality of life in patients thanks to targeted therapy, such as Herceptin. This was the patient's PET scan on August 18, 2012. Most of the disease was in the liver, obviously, as well as some in the bone. And 5 months into HER2 targeted therapy, in January 2013, we had almost a complete response. This is all to say that when I was a medical student, we used to learn that the only cancer in medical oncology where if it is stage 4, it is still okay, was testicular cancer. But this is phasing out. We're having a lot of success, even in metastatic disease, in multiple cancers such as breast cancer or even kidney and bladder. So targeted therapies, I gave some examples like breast cancer, ER positive. We use it from stage 2 to stage 4, HER2 positive, any stage. And lung cancer, there's an explosion of identifying targeted treatments, whether it's anti-EGFR, anti-ALK, anti-ROS, KRAS, G12C, as well BRCA positive tumors with PARP inhibitors. For example, I gave one example in lung cancer. The way we used to think is that lung cancer who are stage 4 have a poor prognosis of 6 months, and it's usually very harsh chemotherapy. But if you are a lung cancer patient and you have what we call EGFR mutation, you can go on an EGFR inhibitor such as osimertinib, and your progression-free survival is dramatically higher than being on chemotherapy. And usually I would say median overall survival on EGFR therapy could be easily in the 16 months to 18 months, which means that stage 4 lung cancer patients with targeted therapies can actually live much longer than how we used to think, I would say 5 to 10 years ago. And that's why we are in this new era. Immunotherapy, I can safely say, and I know there's a couple of my colleagues on this Zoom, we can all agree that it is quickly replacing chemotherapy. The reason I say that is this is a very crude presentation. I actually took it from one of my mentors back in UHN. It was done in 2014, and it showed that if you are on chemotherapy, the percentage of survival when you're metastatic is limited. And with some targeted therapy, it could be better. But lately, we're noticing that with immunotherapy, this graph usually plateaus, the line plateaus. And we see that I focus on kidney cancer in one of my subspecialties. And for example, kidney cancer stage 4 in 2006, we used to treat them with interferon at the Jewish and required intubation sometimes and to go to ICU. And now we can give them dual immunotherapy. Stage 4 kidney cancer, we never mentioned complete response or cure before 2010. This is a presentation of ipilimumab and nivolumab, so dual IO, against the mainstay treatment, which is called sunitinib. And 10% of the patients had complete response at 5 years, and they were cured. This data was presented in 2019. In ESMO, the European Society of Medical Oncology, a couple of months ago, they presented the updated data, and the 10% became 18%. So I would say in medical oncology, it's becoming even harder to tell a stage 4 patient that, as we used to think, life is finite when you have stage 4 disease, because clearly, for example, in kidney cancer, you have a 15% chance, or 1 in 6, that you can actually be cured of your disease, even if it is metastatic and widespread. What about new treatments on the horizon? So I'll give a few examples of new treatments that we started approximately a couple of months ago, and we'll see more and more often. And the reason why it's important is because of the side effects that they bring with and the need on having help from different departments. So enfortumab vedotin is a monoclonal antibody. It's called anti-nectin-4, which is very specific to bladder cancer. And on it, they were able to fuse what we call microtubule disrupting agent, or MMAE. And what happens is enfortumab vedotin is given intravenously, and it will go intracellularly, and this complex will go in, and then the MMAE will be released, causing microtubule disruption and cell death. Now, why is this a very important medication? Because it was given to patients who received multiple lines of chemotherapy and multiple lines of immunotherapy. So those patients were done. They were palliative with an estimated survival of 3 to 4 months. And when they were given enfortumab vedotin, 12% had a complete response at 18 months, and approximately 60% had either stable disease or a partial response of their disease at 12-month time. So this is really unheard of. And very quickly, this medication is becoming approved from the 3rd line to the 1st line therapy. Interestingly enough, given that the medication has only been in trials for approximately 2.5 years to 3, we don't have a lot of understanding about their side effects. For example, on the product monograph, they have to have an HbA1c of less than 7 before starting treatment, or no peripheral neuropathy. But we don't really understand the correlation of how this antibody drug conjugate can affect HbA1c, and I will discuss that in a later slide. Another medication that we started using is trastuzumab deruxtecan. So I did mention previously that HER2-positive breast cancer patients can take Herceptin. We all know Herceptin can cause very rarely cardiac toxicities. But lately, they were able to take trastuzumab and link it through a cleavable linker with a topoisomerase 1 inhibitor called Deruxtecan. And basically what they did is they took the monoclonal antibody and linked it to this cellular cytotoxic agent with a very high payload and a very high potency of the payload, and was given in breast cancer patients. This is a waterfall plot. We rarely see waterfall plots where most of the patients have a huge positive change from baseline of the sum of their breast cancer disease. It's 168 patients, and almost 61% had an objective response rate. 11 patients had complete responses, and 36% had stable disease. Those are breast cancer patients who have HER2-positive metastatic, who failed all lines of treatment, and when they were put on this medication, responded very well. And now we have a special access program where we're putting patients on this medication. However, it does also carry toxicities. And one medication that is also coming in very quickly, it was first introduced in 2017. So barely 4 years, and this is 4 years in oncology is quite fast to go from phase 1 to phase 3 and approvals, is Cellular govitecan, which is an antibody drug conjugate, immunoconjugate. We're becoming actually quite good in creating antibodies and linking them to toxic agents that have a very high drug to antibody ratio, and we have a very high payload that can be very toxic to cancer cells. And this is also a medication that's given in breast cancer and also starting very slowly in GU tumors, where we're having good confirmed objective response rates with a clinical benefit of approximately 45%. So we have a lot of medications that are coming into play, but also what about nuclear medicine? This is something that we've never thought about before. 10 years ago or 20 years ago, radioactive iodine for thyroid, and very rarely we used to give radium to prostate patients, and not a lot of side effects. So the exposure to other departments in internal medicine or under the umbrella of internal medicine, we were not exposed to those patients because we didn't have a lot. But lately, there is an explosion of drugs that are being used through nuclear medicine that are providing, quite impressive results for cancer patients. The most common one that's coming very fast is the 177 Lu PSMA 617. Very simply, in very simple words, it's a beta particle emission that is linked to a PSMA, so a prostate-specific membranous antigen, and it is injected to the patient. And this will go intracellularly. The PSMA will recognize prostate cancer cells, it will link to it, and then the beta particle will be taken intracellularly. And because of the emissions of the beta particle, it will cause DNA damage and apoptosis. The 177 Lu PSMA showed to have 40% reduced risk of death and 60% reduced risk of progression. Mind you, this is compared to standard of care, and we're having excellent responses. It is very tricky to read those scans. I can tell you worldwide, we're having a lot of difficulty on how to compare PSMA imaging compared to traditional imaging. But for example, this patient who had prostate cancer had a lot of bone disease. And after 2 cycles of 177 Lu PSMA therapy, we can see that most bone lesions disappeared. Now, not all centers will have access to the imaging part as well as the treatment part, given that it requires a lot of agents. It requires a lot of personnel from nuclear medicine, and the government doesn't cover it. The only center that has, I would say, a track record of 2 years is the Jewish. And currently, we will start having PSMA imaging and therapy through clinical trials at the MUHC in early 2022. The reason for that is to produce those agents that are not very stable from a radionuclear fashion. They require a lot of experience and require to be injected very quickly to patients. So I don't think we'll be able to provide this therapy to patients except under trials. And they're very cytotoxic. They can cause myelosuppression. I know that at the Jewish, they gave it to 5 patients and 1 patient died due to profound cytopenias. Why is it important? Because I did realize that if patients start getting treated on PSMA or with PSMA therapy, there is no way if the patient goes to ER that we can detect those patients very easily, because in OASIS, they will only be listed under imaging. So it could be very easily missed that those patients are on this kind of therapy, and nuclear medicine do not write usually notes in OWORD. So we're trying right now to figure out a way to flag those patients should they come with profound cytopenias to the emergency room. Okay, what about side effects of immunotherapy? The reason why I'm presenting the side effects of immunotherapy is because with more and more immunotherapy medications being given to our patients, the higher the likelihood that we will have patients presenting to the emergency room or being seen by other departments. And what is very crucial is to understand how to treat those patients. We started flagging issues with management of those patients in ER, and we did meet as a department, and we're creating standardized immune-related adverse events guidelines in order to help everybody, especially in the emergency room, on how to manage those patients. The most common timelines, and very quickly after we give immunotherapy, skin side effects are the most common, as well as thyroid, such as hypothyroidism. Less common, but also seen, are liver toxicities, as well as colitis, and much rarer and more toxic with higher mortality are pneumonitis, encephalitis, as well as myocarditis. The first step that you should do, and this is what I do when I go to the emergency room, is to try to quantify the side effect when people are on antibody drug conjugates or when they are on immunotherapy. So the first thing we do is, I do it all the time. I go on Google, I write CTCAE version 5 or V5. CTCAE stands for Common Terminology Criteria of Adverse Events. It basically quantifies the adverse event under a 5 grading system. Grade 5 is usually death. The moment you write it on Google, it is the first link. So the moment we click on the link, you'll get the PDF. It is old. It's been since 2017. However, it's used around the world. So we can communicate among each other. Oncologists around the world can communicate about side effects just by using the same adverse event criteria. So for example, I just did a quick search for diarrhea. If you look diarrhea, it's defined as grade 1. If less than 4 stools increase per day from baseline, grade 2 is 4 to 6 stools, 7 or more is grade 3, and life-threatening is 4, death is 5. So for example, if you have a patient who comes to the emergency room, we realize they are on an immunotherapy. First question is, how many bowel movements are you having more than normal? We can quickly identify the grading of their side effect. And then using any of the guidelines that we have published, you can manage the patients quite easily, even without medical oncology. It's always better with medical oncology though. The two most famous practice guidelines are the Europeans with their ESMO clinical practice guidelines, but we use the American Society of Clinical Oncology practice guidelines. They're up for an update. Their first publication was in 2015. The second time they were revised was in 2017. The only thing that changed was insisting that we have to be very aggressive early on in our management of the side effects of checkpoint inhibitors. The reason for that is if we do not calm down the immune system very quickly early on, mortality in those patients can become quite high. And lately, when I was in the emergency room, we had 2 patients, one with panencephalitis and one with myocarditis, and they both died within 24 hours of presentation to the emergency room. It can be quite toxic and quite deadly. If you just write on Google, immune-related adverse events, ASCO, you will find the PDF and you can search for the organ being involved. And based on the grading using the CTCAE, you'll know how to manage the patient. Now, how do we manage the side effects? I should say the worse the side effect, the quicker the steroids are given, the better the outcome. And I included side effects from every single department, I would say, under internal medicine. The first one, the most common one, is skin, so dermatology. If it is less than 30% of the body surface area, usually us oncologists usually treat those patients in our clinics with topical steroids, and usually they're able to tolerate more of the immunotherapy medication. However, if the rash becomes more than 30% or having a lot of symptoms such as uncontrolled itching or bullae, what we do is we continue with the topical treatments, but this is when we start prednisone PO, 0.5 to 1 milligram per kilogram. The trick in all of the side effects, depending on the organ, is the dose of the steroid, as well as if the steroid is given IV or PO. So honestly, it's very hard to memorize when you have so many organs. So this is why I always refer to the ASCO guidelines. The reason why I'm presenting this is because the moment we have a grade 3, we have to get dermatology, quickly see the patient and biopsy the patient as soon as possible, given that the moment you start giving IV methylpred, for example, the rash can subside very quickly and we can miss the diagnosis. So this is why things have to be done very quickly. And if we do a punch biopsy, we should alert the pathologist to read it very quickly. All we need to know is, do you see any white blood cells that are causing an inflammation in the skin? If it is a grade 4, so more than 30%, and there's erythema or epidermal detachment, then the treatment would be IV methylprednisolone. In terms of endocrinology, the most common one is the thyroid. We see a transient hyperthyroidism at the beginning, especially if we do a lot of TSHs, if we see the patient every 3 weeks. When they are in the transient hyperthyroidism, we usually do not treat. It is only a sign for us that they will become hypothyroid soon. The moment we start realizing or seeing the TSH elevated with a normal free T4, we can start Synthroid at that time, but we should definitely start synthroid when the patient is symptomatic with a high TSH and a low free T4, and it's usually synthroid 1 microgram per kilo per day. In terms of GI side effects, there are two common ones. The one that is more worrisome is usually hepatitis. It all goes through the ALT and AST gradient. If it is less than 5 times upper limit of normal, we usually check the patient. We do blood tests serially, approximately 3 times a week. And it is a judgment call, I would say, to start oral prednisolone. But at the same time, we should do all the screening, especially the Hep serologies and all the possible autoimmune, like anti-ANA, SMA, and iron studies. The moment we have AST or ALT above 5 times the upper limit of normal, this is when we have to involve GI or hepatology very quickly to an ultrasound with the Doppler and think if we should biopsy or not. And usually if the AST, ALT are less than 400 with a normal bilirubin and INR, we treat with prednisolone PO. But if it is higher than 400, the treatment is IV methylpred 2 milligram per kilo. The error that we see sometimes is that we don't feel comfortable with high doses of methylpred, or sometimes we decide to do it Q4 or Q6 or Q8. But this is not a regular autoimmune disease that we're facing. This is a severe, I would say, immune storm. So what we need to do is to give high dose steroids, and it's usually methylpred 2 milligram per kilo once daily, very quickly, that we have to give. In terms of colitis, if it is a very not severe diarrhea, so if it's less than, if it's 6 or less stools per day than the upper limit of normal, we usually treat with loperamide. However, if you have a persistent grade 2 diarrhea or a severe grade 2, 3, or 4 that require presentation to the emergency room, this is when we stop the immunotherapy. We do not give oral prednisone. We actually give IV corticosteroids. And it is also high dose, 1 to 2 milligrams per kilo. And we have to continue it for a quite long time. And this is another error that we see, is we get very excited that the patient, responded in 3 days, and we do a quick taper over 2 weeks, and then the patient comes back to the emergency room. So this is not, Crohn or ulcerative colitis that you can do a quick switch with a quick taper. Given that this is immune-related adverse event, the way we should do it is a very slow taper, not even less than an 8-week duration. So it has to be done very slowly. If corticosteroids don't work, at that time we can consider infliximab or MMF as our second-line therapy. The challenge would be in respirology. All the previous one that I presented, we have very clear clinical presentation, or we have a blood test that quickly helps us identify the grading. In pneumonitis, it's actually quite difficult to differentiate between immune-related pneumonitis versus an infection. And we tend to rely always on a high-resolution CT scan with a bronchoscopy or a bronchoalveolar lavage. The moment the person has a grade 2 adverse event, this is when respirology has to be involved. So earlier on than other departments. And the management is also very aggressive. It's usually prednisolone 1 milligram per kilo. If it is grade 3 or grade 4, it is methylpred 2 milligrams per kilogram per day, and we start empiric antibiotic therapy. If the patient doesn't do well within 48 hours, so we have to do the judgment call very quickly on. It's not, O2 improved by, going down from 5 liters to 4. That's not an improvement. The patient has to be much better. So in 48 hours, they're not well, we usually add infliximab 5 milligrams per kilo or MMF. Neurologically, the most common is Guillain-Barré or myasthenia gravis. In both presentations, once the patient presents to the ER, we have to quickly do a lumbar puncture or get ophthalmology to do an ocular exam. I know it's quite challenging sometimes to get ophthalmology very quickly, but this is also the need of, pushing quite fast for those patients, given that the time is against them. And we start with very high doses of methylpred in case of Guillain-Barré. If it is myasthenia gravis, we start with pyridostigmine, initially at 30 milligrams, and then we do the neuroconsult, and then consider plasmapheresis or IVIG. Under cardiac, Cardiac is becoming trickier with time. I'll explain why soon, but cardiac side effects have been reported with every single immunotherapy medication we gave. Usually it's less than 2 to 3%. It is very, dramatic, the presentation. We have a very high trope with a patient who doesn't have chest pain or EKG changes. But the most important is getting a very early consultation with the cardiologist to rule out a STEMI or an unstable angina, and very quickly start high-dose corticosteroids. You have nothing to lose. If the patient's having, pseudo-MIs, we're not really convinced it's an MI, just give the high-dose steroids and see what happens, because the cardiac mortality is above 60 to 70% when the patient presents to the emergency room. And finally, nephrology. This way, nobody is left behind under internal medicine. So in nephrology, if you have creatinine that's 3 times the upper limit of normal, we should quickly admit the patients, check their fluid balance, repeat the creat every 24 hours, get nephrology involved, as well as think of a biopsy, and quickly start also IV methylpred. So in the rarer cases, as you notice, the treatment is usually IV steroids, versus in side effects that are usually calmer, like the skin, it is prednisone PO. So what happened is that I would say prior to IO, oncologists used to treat patients very comfortably by themselves, not a lot of need from other departments to get involved. With immunotherapy coming in, as well as antibody drug conjugates, cancer patients are more and more commonly seen by different departments, whether we like it or not: dermatology, endocrino, cardio, GIM, especially in ER, and obviously helping us admit those patients, nephrology, GI, RESP, neurology, as well as us. The conclusion of the management, I think what's very important is, please check the CTCAE version 5 and the ASCO guidelines. They're extremely well written. It is really not hard to read. There's beautiful tables. It tells you if this is the grade, this is what you need to do. They will be revised shortly, and I do suspect what they will recommend is even higher doses of steroids, as well as starting MMF or infliximab even earlier than, I would say, the 3 or 5 day mark. Do not hesitate to start steroids. Just ensure the workup is done. For example, in colitis, make sure that we quickly get that C. diff out of the way so we can start and not get the C. diff, 24 or 36 hours later while we're waiting before giving the pred. Also check if it is pred PO or methylpred IV. And it's always daily. It's not Q8, it's not Q6. And at least give it for 3 to 5 days before you change the dose. Don't change the dose the moment the patient starts better. Give the patient 36 to 48 hours of being very stable before switching the medication's dose or switching the route from IV to PO. A quick medical oncology consult is needed. Obviously, will help you, tell you, how to refer the patients, when to do the conversion, and what are the things to watch out for. If the patient is not better in 3 days, this is a big message. We will need more aggressive management. Why? Because mortality increases. For example, if a patient has a myocarditis and the trope is 7,000 and went to 3,000, but the patient's oxygen demand is still 5 liters, we're still giving him Lasix 40 milligrams IV BID. This is not a patient that's getting better because the troponin improved. This is a patient that's actually not doing so good, and we need to push for more aggressive management. So the other thing that we notice is tapering of steroids. There is no quick tapering of steroids. Patients get very edgy because they know that the moment they are on steroids, they cannot pursue more therapy. But we always have to be safe. We don't want the patients to come back to the emergency room. We don't want another flare. We will definitely be able to help you out with tapering the steroids, but the usual rule of thumb is the steroids should be tapered over at least 6 to 8 weeks. And also, if you have somebody with cardiac and myocarditis, avoid infliximab in moderate to severe heart failure. Unclear management. So some things just to tease our brains because it's too early in the game. For example, in enfortumab vedotin, the antibody drug conjugate that I presented, the product monograph says that HbA1c should be less than 7 prior to therapy. In their trials, they did not include uncontrolled diabetics or diabetics with an HbA1c above 7. So the question is, what is really the mechanism of action with type 2 diabetic patients? It's unknown at this time. The other question is, if we know that a diabetic patient, for example, who is insulin dependent, who really needs to go on this medication, how should we treat those patients? Should we be very aggressive? Should we wait for the HbA1c to go down, which usually, if I'm not mistaken, takes between 6 to 8 weeks to start changing once we have a better control on the sugars? Can the patients wait 6 to 8 weeks? We don't know. Which patients should we empirically give metformin to? Is it, for example, someone who is not known to be diabetic and we just diagnose them with diabetes? Should we start quickly with metformin? Because let's not forget, most bladder patients do have chronic kidney disease. Most of them had a cystectomy or a nephrectomy. So they have one kidney, or really not very well functioning ureters, because maybe the mass is constricting the ureter. So which medications or which anti-diabetic medications should we give those patients? In Trastuzumab Deruxtecan, when they published this in the New England Journal of Medicine in 2019, they noticed that patients did very well, except from a lung perspective. They actually had 4 people who died due to interstitial lung disease. Until now, they don't really understand what is the etiology behind the antibody drug conjugate, IO conjugate with the lung. But what they noticed is that there was 13% of the population that took the medication had some kind of respiratory adverse event that is linked to the interstitium. We don't know how to manage those patients. We rely on management from immune therapy or the standard interstitial lung disease way, which is give corticosteroids and let's see what happens. What they agreed upon during treatment, they did not want to stop the trial. And the reason why they did not want to stop the trial is they were seeing a lot of tumor response rates. So their grade 3 adverse event or grade 4, grade 5 were not that high to necessitate to stop the trial too early. But they did have 17 patients, who had grade 2 or more ILD. They were given corticosteroids, 7 only recovered. At the time when this paper was published, 2 were still recovering, and 12, either the outcome was unknown or not followed until resolution. It's not really common to give a treatment and tell patients you have 1 in 6 chance of having interstitial lung disease. But also, let's not forget, those are breast cancer patients. Some of those breast cancer patients already received radiation to the breast. The lungs are exposed to that radiation. Does that mean that they are at a higher chance of developing interstitial lung disease? The other question that we can ask also is this the same pathology as a regular interstitial lung disease that is not oncological in nature or not driven by an antibody drug conjugate? So should we treat it the same way? Now we only have, I would say, 1.5 years of experience with this medication. So nobody knows. However, the recommendation right now is to give aggressive steroids if people push for this medication. The question is, should we PFT everybody? Should we CT scan everybody at the beginning? There's really not much clear guidelines on how to proceed on those. Finally, this was a publication in Circulation in 2019. So it's a very well-respected journal, and it was an oncological patient being presented in a cardiology journal. And more often, we're seeing immune-related myocarditis with a very normal workup with just an abnormal EKG. In this paper, what they showed is a patient with an abnormal EKG high trope, but when they did the Dept, maybe when they did the cath, everything was normal. The thing that really made the difference in the management of this patient was a very early cardiology consult to a specialized cardiologist in oncology who decided within 24 hours of the patient being presented to the emergency room to proceed with a cardiac biopsy. And the moment they did the cardiac biopsy, they saw the huge inflammation that the patient had and started aggressive therapy. So it doesn't really mean that if you have a side effect in one organ, that if you do quick imaging or the normal imaging, that we will detect the adverse event. For example, here they did all the workup and all the workup was negative. We really had to go to a biopsy. And we do know that in our center, sometimes it's very hard to get biopsies done within 24 to 48 hours. But those hours actually make a huge difference in the patient's outcome. What is the future at the MUHC? I think I'll just spend the last 5 minutes explaining what what is the vision in oncology, how we're moving forward, because this will definitely implicate other departments. So what is coming up? Enfortumab vedotin and other antibody drug conjugates will be present. I actually treated the first patient on enfortumab vedotin 3 months ago on clinical trial. We have so far 4 patients on this medication. We do know that the Trastuzumab Deruxtecan, there's a few patients who are on it. One patient actually came to the emergency room and got admitted to our floor on D10 due to adverse event from the medication. So slowly but surely, we will see patients not on chemotherapy, but more on those medications. And you'll say, what is this medication? What does it do? We'll have to really focus on their side effects and become more familiar with them. PSMA trials, as of end of January, will have a compassionate access to patients who have failed all standard of care in prostate cancer, as well as there will be a clinical trial with Novartis that will open, I hope, beginning of February. The challenge with those trials, or the challenge with PSMA, is, as I mentioned before, is that the only way you can see the treatment being given is through OASIS imaging. You'll see it under imaging, so it can very well be missed, especially in the emergency room. PSMA trials are toxic. There is, I would say, an 18 to 20% chance of myelosuppression. We'll definitely have more phase 1 trials. There is some phase 1 trials occurring at the moment, but we'll have more phase 1 trials coming in that could be toxic to patients. Before COVID, cytokine release syndrome was something that we saw in phase 1 trials because the medications are becoming way more potent and activate the immune system in a very intense way. So I do suspect we will see more patients in phase 1 that can have cytokine release syndrome. We treat them with tocilizumab usually. There is more CAR T therapy. Dr. Sebag leads that in hematology. They had a very successful patient on the ZUMA trial with CAR T who had leukemia, but now CAR T therapy is being pushed to solid malignancies. The only center that does this right now is Princess Margaret in Toronto. They tried it on few breast cancer patients, but there was no success. But there have been some success noted in lung cancer patients. What does this mean to us at the MHC? CAR T patients, you cannot treat them as outpatients. That's number one. And number two, it is not a short stay admission. It's not a 30-day admission. It can be very well be 60 to 80-day admissions if the patient has a lot of side effects. So that will definitely put a burden on our system. Finally, one thing that we've been discussing in our department is to create immune therapy management guidelines that will be helpful to us in our clinics as well as in our oncology day clinic, but also to have those guidelines in ER, whether on MedUrge or shared with the GIM team. So we have a standardized way of managing all the patients irrespective of where they are. The SHUM already have their own set of guidelines. They use more the European Society of Medical Oncology guidelines. It's not very broad, so we're trying to learn from the positivities of their guidelines as well as their weaknesses in order to implement ours. So hopefully we'll have something, I would say, in the next 4 to 6 months where it will be presented, especially to the ER teams and the GIM teams, so they know how to manage those patients. The challenge right now that we face is, for example, as medical oncologists, we cannot access infliximab without GI approval, or some other medications without getting other departments approved. So hopefully, if we have a system in place, we can quickly access the medications and treat the patients quite fast. The last thing is we are in the process, we finalized this actually, but hopefully soon patients who go on phase 1 trials will have their OWARD document in, and hopefully this will go to all oncology patients. But this way, when the patients present to other departments, we'll have a very clear OWARD document that will explain what the patient is on and who to contact. For example, here, you have the identification of the patient, you'll know which kind of trial the patient is on, what is the name of the trial, what is the description of the trial, who to talk to, who's the doctor, who's the coordinator, their extensions, and also what is the patient on. You will see this under the regular tabs, the document viewer of OASIS, but this will be very helpful for everybody in order to know what the patient is on, what medications to give or not to give those patients. So finally, I'll just conclude that very quickly, our cancer patients are not being treated only by oncology. Slowly but surely, there will be more and more involvement of different departments to help manage the cancer patients. And that's it. Thank you.
Thank you so much. Really terrific presentation, a wonderful overview of cancer and what's new, and most importantly, great to see some progress being made in this field. We have quite a few questions. I'm going to start with Sasha Bernatsky, who's asking, for diarrhea, don't you have to rule out infections, CMV or so on, or do you wait for C. diff to come back? So in your treatments, when you have diarrhea, how aggressively do you pursue treatments, or do you wait?
So if you have a grade 1 or grade 2, you can very much wait because the patient is not that symptomatic and does not necessitate an ER visit. In grade 3, I would say the most important thing is to get the C. diff. That's what I mentioned in the presentation. But don't wait 3-4 days for the CMV. I know that they run them, for example, on a certain day. Because if we wait, it will become much harder to control those patients. I took the immunotherapy. 3 days later, I started having diarrhea. I don't have a fever. We just do the C. diff just to ensure, but I would not wait for the others before starting therapy.
Okay. Another question here is, if high-dose steroids will be used more liberally, is there a protocol in place to manage and monitor for steroid-related complications, hyperglycemia, for example?
Excellent question. The answer is no. I think the first priority, I would say, is to do a protocol on how to use the steroids. And then the second step would be how to manage the side effects of those patients. I think what brings a lot of uncomfortableness to non-oncology staff is when you have a patient on methylpred, let's say 150 milligrams per day for 5 days, and then we get worried about those adverse events. So you're right. Probably that's what we should integrate also in our protocols.
Dr. Schwartzman wants to know, what, if any, is the approach to reinitiating IO treatment in patients who have developed a significant immune-related complication?
That's a very tricky question. I would say if somebody comes with a clear grade 4 adverse event, immune therapy should not be given anymore. The patient should be flagged. However, if it is a grade 3 or grade 2, this is when we can make a judgment call at that point. For example, a grade 3 skin reaction, you can give immunotherapy again, but if you have a grade 3 pneumonitis, you should not treat that again. As a department, we're doing retrospective analysis to see those patients and how we manage them, but also in the protocol, we'll have a tab that says, if it is grade 3 or 4, to flag it to the primary MD, so they're aware not to proceed again with immunotherapy.
Okay, Dr. Morris wants to know, given the rate of endocrinologic complications, should all immunotherapy patients be screened routinely, including HbA1c? This is not happening currently.
That is an excellent question. What I think right now, with the help of Dr. Legler, Christine Legler, we're able to standardize our prescriptions where, for example, all immunotherapy prescriptions get a TSH at every visit, so we don't miss hypothyroidism. I think the most important thing to be done would be Hep screening on arrival. The reason being, if we do Hep B screening, if they have any colitis or any GI side effects during their course of treatment, we don't need to wait for those serologies. We already have them at hand. For HbA1c, I think we're probably 1 to 2 years away from standardizing HbA1c. Right now, it's only enfortumab vedotin that requires HbA1c, but I suspect that more antibody drug conjugates that are going to come into play that might force us to do HbA1c also screening.
Could you give us an idea of all these new therapies, just a ballpark idea of costs per patient? Is there data on cost per patient, quality life-adjusted costs?
That's actually an excellent question. So immunotherapy at the beginning used to be in the $200,000 range. Now it's cheaper. We're at $3,000, I would say, a month. Enfortumab vedotin, for example, is almost $20,000 a month. Given that the medications are too early, it's very hard to justify quality. The only thing that we did, this is a trial that I did in Toronto, we will publish it soon, is, right now a lot of people talk about sequencing the cancer. But what we found out is that we have the largest pool actually in the world, 4,000 patients that got sequenced at Princess Margaret. And we found out only 2.5% of those had a mutation that was targeted. So in terms of cost effectiveness, there is no cost effectiveness in screening everybody, and that is already a burden because the government is not allowing us to screen everybody. And I do suspect that if we use this data to do a quali, it's not going to be that great in terms of numbers.
Emily McDonald wants to know, what sort of standards should we require for trials of targeted therapies? Do we still require placebo-controlled randomized trials? I'm on some committees where some participants argue this isn't needed as treatment is targeted, so decrease size of the tumor in uncontrolled trial is enough.
So in phase 1 trials, there is no randomization, so that's easy. There's no placebo in those arms. I think she's right in a lot of ways. And I think lately this is changing. Some of the trials are allowing crossover because we're realizing that the medications are way more potent. And during interim analysis, we see a lot of positive responses that we allow crossover from the people who are on the placebo to the treatment arm. And I think this is how it should be moving forward. I think putting patients at a huge disadvantage, knowing that they are on a standard of care that are not doing that great without giving them the opportunity to do the crossover, is truly unfair. And this is changing in oncology for sure. I can tell you in immunotherapy trials, a lot of the trials stopped way too early, unblinded the patients, and then put them on the immunotherapy afterwards so they can take advantage of that.
A couple of questions from Sasha Bernatsky. One, remind us where we find the treatment algorithms for what you showed. And two, do patients in north and rural areas have the same access to these drugs as those in urban areas?
So the treatment algorithm that I showed, all you have to do on Google is write ASCO. I'm going to write it. So ASCO immune-related adverse events. And then you'll see the PDF format. And this is how we can manage. Two, absolutely not. I mean, Quebec is at a disadvantage on Ontario. This is, just province-wide, we're the second best province, I would say, in accessibility to the cutting-edge drugs. And for sure, the north and rural areas will not have access to the immunotherapy or the antibody drug conjugates because it requires a lot of specialized, MDs, techs. For example, the PSMA, I think there will be only 3 centers in all of Quebec that will do it over the next 3 to 4 years. That will be only the Jewish, the MHC, and the CHUM. I don't expect other centers to be able to afford the cost, neither the training required.
Just a comment here from Safa Berkati to please include an ID specialist to review the protocol for prevention and management of CS-related ID complications. So something to keep in mind.
Sure.
Perhaps. And Patricia Zelli wants to know, what is the percentage of patients that get these side effects and develop symptoms that are severe enough to necessitate an emergency room visit?
So that's an excellent question. So there was actually a Royal College question in medical oncology. So the rule of thumb is as follows. If you have a dual immunotherapy, so a combination of 2 drugs, during the course of your treatment, and that's what I tell students, during the course of the patient's treatment, you have a 60% chance of having a side effect, and it could be minor, grade 1 or grade 2. There is a 20 to 30% chance if you're on dual that you have a grade 3 or grade 4. So 20%, that's high. The grade 3, grade 4 means ER visit. If you're on single agent, it is lower. It's usually between 10 and 15% grade 3 or grade 4 adverse event. But again, the same thing, 40 to 50% you can have a grade 1 or a grade 2. I would say, that includes a skin rash, that's a very small rash, or just hypothyroidism that are very easily managed in the outpatient setting. The most important thing, and that's because I did a lot of consult service, especially last year, I realized that sometimes those patients go to GIM before medical oncology, and there's this discrepancy, should we not start steroids? I think the biggest message is don't be scared to start steroids, but also don't give a baby dose of steroids at the beginning. You know, when we had the myocarditis case 5 weeks ago, Risa's 55 in the ER, I was speaking to the cardiologist. I told him, is there a problem if I give methylpred 2 milligrams per kilo? It doesn't look like a STEMI for me, and you will do the cath tomorrow. He said, no, not at all. So just give. And that's what we did. So the most important message is if they come to the ER, check quickly the link that I provided, and Sasha actually provided it too. And if you think it's warranted to give the steroids, just give.
Fantastic. So that is the correct link then that Sasha put there. So if you want to hold on to that link for everyone who works in the hospital as a clinician, it can be a useful link. Thank you so much. Really a wonderful presentation, and really interesting to see these advancements, and hopefully we'll have you back, you know, in a year, and you can tell us further advancements. Congratulations on the work you've done in this area, and thank you very much for bringing this presentation to us today, and thanks everyone for participating. Have a great afternoon. Bye-bye.